Welcome back to Trach Talk. I'm Daryl. This is Tom. We're going to talk about routine tracheostomy care and suctioning. So, if you want to know the policy on routine tracheostomy care, you can search under Policy Stat, Tracheostomy Care, and you will find this. The very first line on this policy here says, routine tracheostomy care is the responsibility of the RN or LPN. I asked if we could get this policy changed to have the RTs doing this, because this is really our thing. And the education people said, we want to increase the nurses' confidence through increased contact with more trach time. So here we are. Let's move forward. Before you get started, you're going to need some stuff. The RTs will have provided you a few things. Here on the tracheostomy suction safety card is the stuff the RTs will have provided you. You have some emergency equipment, your bag, your replacement trachs, and a size down trach if necessary. But most importantly is there's trach ties and inner cannulas where applicable. Trach care is to be done BID. The inner cannula is supposed to be changed daily. So I would like to say have day shift change the inner cannula just so that we're not using more stuff that we need to. But there's no harm in changing the inner cannula more frequently than necessary. So let's get started. I like to put a towel or a chuck on my patient's chest in case something nasty gets on them. It's much easier to pick that up than anything else. So we will start by removing this gauze. This will have caught most of the mess from your stoma. There's a lot of drainage that comes out of there, and this will usually get it. If not, I'll come back with this or a clean piece of gauze and kind of mop up underneath there and pinch it up as necessary and get rid of it. Then, sterile saline. I like using a sterile saline flush. Pull the plunger out of it, and then take one of your Q-tips, drop it in there. Get it nice and wet, and you'll have dry Q-tips off to the side. Take your wet Q-tip, get up underneath this flange, lift it up if you need to a little bit, and you want to use a rolling motion. You want to use a rolling motion as you twist this to push any debris or anything away from the stoma. It is important to not be scrubbing like this where you can possibly be pushing something into the stoma where it's going to get fester and get infected. Also, the Q-tips, nothing ever gets into the stoma. You don't push this in there, you're just cleaning around the stoma. If you find that there's something wrong there, a wound or increased redness, something doesn't look right with the skin, initiate a wound care consult and the wound care team will help you with the appropriate action. So, I will clean on bottom, discard this, get a fresh one, clean the top, clean around it, discard those, then take my dry Q-tips and do the exact same thing. Come back and dry up that extra saline. If there's any other goobers or something, make sure that you have a clean surface to work with. Once you are done, you can change the inner cannula. Up here will give you a close-up with another trach. The inner cannula is this little piece that sticks out here. Grab a hold of it, pinch it ever so slightly, and the whole thing comes right out. It is nearly effortless. If you feel like you're pulling too hard on it, you probably have a hold of the wrong piece. Just give a little pinch there on the end and pull it out. Or here on top, I can just reach up, grab a hold of it, and pull it right out. Get a fresh one out of a package and slide it right in until it clicks. Your tracheostomy ties can be changed at this time. It's a little easier to change with the gauze out of there. The trach ties are to be changed PRN. There's nothing scheduled there. It's just if they're soiled or if your patient's skin doesn't look quite right, you can take those off, clean around their neck, and put new ties on. When you're done with these ties, you want to be able to just barely put 2 fingers in here without stretching the ties or stretching their neck. A little bit of slackness so that they get good blood return through their jugulars. You're not putting extra pressure on their trachea, but not so much looseness that the tracheostomy stands a risk of coming out. 2 fingers in between the ties, and you're good to go. Then you can take your new gauze. The type of gauze is important. Non-woven gauze that is already split is just the ticket. Using woven gauze that you have cut with scissors is a no-no. Woven gauze can break off little pieces and get into the stoma and worsen an infection or cause an infection. You definitely don't need that. So get out your gauze. Some patients have a preference of one piece of gauze or two, depending on how much cushion that they want on their throat. I like to fold this down, shove it up there underneath the trach, and then do one side at a time. This is a lot of fun with a screaming baby with a trach. Adults are a walk in the park. And make sure that that gets up there underneath the bottom of the flange. The most important part of this whole part is this bottom end of the flange here can dig into their neck a little bit, and providing that little bit of cushion will save them from having a wound. You are all done with tracheostomy care. Let your RT know if you have any questions, what to do with any of that. Next up is suctioning. Draw your attention one more time to our tracheostomy safety card. Your RT will fill this thing out. It'll have the trach size, what kind of trach that they have, and my safe suction depth. This is determined by how long the trach is inside of their body. So let's just say that this trach, the safe suction depth is 12. So on every suction catheter, they have printed these numbers on there. That is the distance from the tip of the suction catheter to that mark. So if I insert this one to 12 centimeters, just barely, this will poke out of the end. So safe suction is where your suction catheter will never encounter the patient's mucosa. The inside of your trachea is very sensitive. You can get breakdown in there very easily, and that will lengthen their stay, increase their secretions, bad stuff. So most of your suctioning should be with safe suction. Get them to cough a little bit, move those secretions up into their trach tube where it's easier to suck out with that safe suction depth. However, that's not the world. We don't live in this fantasy land all the time. Sometimes you must go a little deeper. It's important to notice how much more suction catheter I have. This whole suction catheter does not go in there. Push this in gently until you meet very gentle resistance or until your patient coughs. Then apply suction and remove your suction catheter. From start to finish, when you put this in the end of their trach tube until you are all done, should take no longer than 10 seconds. If it takes longer than that, you're doing it wrong. These patients are already decompensated enough to have a tracheostomy. They can't handle having all the air sucked out of their lungs and have this happen for an extended period of time. Be mindful of that. Also, suctioning is an aseptic technique. So every suction catheter comes with sterile gloves. Maintain a clean hand and a dirty hand, and only the clean hand touches the suction catheter. If you have questions about this, your floor RT will be more than happy to help teach you how to suction correctly. Every once in a while, your patient will have an inline suction catheter, and I have one here somewhere. Inline suction catheter. If you work in the ER or the ICU, you've probably seen these on ET tubes. This is exactly what it is. Support the airway and insert this into your safe suction depth. You can look through the window right here, and you'll be able to see through this clear part how deep you are in that patient's airway. And if you need to go deeper, you need to go a little deeper. That's fine. Lavaging. Some people like to lavage as a matter of habit and just routine. I encourage people to not lavage as routine. It's not good for your patient. No one wants to have liquid put down inside their airway, and plus it increases the possibility of infection and worsens infections. There's time to lavage, but if you feel like you're not getting what you need to with lots of suctioning, call your RT. We have a few tricks up our sleeves, and hopefully we can get that out with lavaging them. Thanks again. We'll see you next time on Trach Talk.